Hello, my name is Stephen Prakken. I'm an MD from Duke, currently serving as the Director of the Medical Pain Service within Duke Pain Medicine. My daily work primarily involves the medical management of pain patients with comorbid psychiatric disease. Most are suffering from complex conditions, along with multifactorial psychiatric illness, including personality disorders, substance use disorders, depression, anxiety, mood instability, etc. My training is in psychiatry with additional boarding and pain management. I've had the privilege to be doing this for many years now. Today, I'm going to present some material that may help in the understanding of pain patients in a different way, looking at how they may affect us as practitioners and as human beings with our own frailties and issues. In the previous segment, we discussed the realities of pain, what that does to a person's felt sense of control and their mood, and how it can lead to catastrophizing, rumination, and impulsivity. With that background in place, I want to talk today a little bit more about what actually happens in the room with a pain patient. The problem with pain patients, and all patients actually, is that they happen to be human. They have personalities and frailties. They have fears and assumptions and agendas, very personal to them, that arise out of all the various aspects of themselves. And the problem with physicians is that they suffer from exactly the same thing. We have our own assumptions and agendas. This is part of being human and alive. When this normal human tendency is mixed with chronic pain and personality traits, then it's not uncommon for practitioners to feel the warning flares go off, right? We start to worry, begin reading more into small signs and expressions, all more than intended or necessary. This also is normal human behavior and nothing to feel guilty about. It's just something that we need to be aware of. So how do we work with pain patients in the room? What do we have to do in the moment to keep our equilibrium and have a good outcome? The first axiom I would like to tell you about is the one that's also my favorite bumper sticker. Do not believe everything you think. This does not mean ignore everything you think. It does not mean believe all the stories that you might tell yourself, right? The body abhors a vacuum. We learn that in medical school. And it also applies to our thinking and understanding. If we do not know something about someone, we will make assumptions structured from our own personalities and apply that to the person sitting in front of us. Again, this is normal human behavior. And our patients do it to us and we do it to them. Another way of talking about this is how you feel about someone is only worth a plain film. Your first gut feeling, though quite strong, has limited information. It may help direct you to further questions, but the gut feeling is not worth a clinical decision. When the patient makes assumptions about you, it can feel very personal, like an attack or lack of cooperation. But as we have seen, it actually has nothing to do with you. People tend to make the same kind of assumptions over and over about situations and people. It's part of their personality structure, and it's in every one of us. And it is something that is very hard to change. An easy example is the following. Think about long-term relationships you have been in. Have you had fights in those long-term relationships? Have you started some of the fights in your long-term relationships? Inside that loving long-term relationship, have you tried to change some of your behaviors such that you did not start the fights as much? The answer to all of these questions, for only like 98% of us, is a resounding yes. Have we been able to substantially change our behavior? Again, on only about 98% of us, a resounding no. If we cannot change our own behavior, how can we expect to have our patients change their behavior? Why should we take it personally if they do not do what we ask them and just change their behavior? This is not meant to be a good reason to just stop, trying, roll over, quit pain management. The simple fact that change is incredibly difficult makes these people predictable. I know they're going to continue to be anxious or irritable or distracted or impulsive. And if I can predict these things, I know what to do with my interventions. Right? Another confusing and troublesome quality that some difficult pain patients have is something I call poor affective constancy. These are people that make a decision today that they cannot keep tomorrow. We all make decisions, hopefully, with a combination of how we feel and how we think at the same time. Some people make decisions actually primarily through just how they feel. Somebody can be in the room with you and make promises that are authentically discussed and authentically given. But when they come back in a month, they have done the exact wrong thing, the thing you asked them not to do, the thing they promised they would never do again. How is this possible? They do not have affective constancy. In the moment when they're with you in the office, they're in an emotional state that permits them to make a promise to you and themselves. Later, by days, weeks, hours sometimes, when they have a different emotional state, they will make a different decision. Again, authentically and seemingly rational. They do not have the ability to keep and maintain emotional understanding that they use to obtain the original decision. They're overwhelmed by a new emotional state. The new state demands a different decision, and they're incapable of withstanding that demand. This is one of the cores of impulsivity that is seen with many of the pain patients and very frustrating for practitioners. But they're not lying, they're not manipulative, they're not being insincere. They just don't have the capacity to keep their emotions and their decisions separate. This is what happens with our patients, and once again, we cannot expect them to suddenly change. They do not have the capacity. This is the patient who is short on meds repeatedly. I have talked with them a number of times, have looked at criteria, see that they're not addicts, have checked the UDS and the CRS, all consistent, yet they are short on their meds over and over. They talk about just needing a little bit better pain control at times. To this group, I will not give a monthly supply of meds. I will give them 4 weeks, each with a script. They'll walk out of my door with 4 separate scripts, all dated to fill week after week. And it's my job to be able to predict this behavior, not set them up for failure, that later I get to call addiction or disrespect or breaking the contract or for manipulating for more meds, right? This was something I knew was going to happen. It's me needing to make sure I can predict this. So now let's talk about going into the room and sitting down with the pain patient. What do I need to remember? We've talked a lot about basic structure, but as you walk into the room, the moment-to-moment dynamic also starts. So remember as you walk in the room a number of human realities. First of all, everyone makes mistakes. Everyone has difficult personality features. Everyone has hidden behaviors. Everyone has some level of anxiety that shapes their behavior. So I walk into the room. The patient knows that I have control over large segments of their life, and they will start to act, manifest all the elements we have talked about. As physicians in this somewhat charged situation, we'll be watching for small signs to guide us. We will see them try to hide their mistakes. Their difficult personalities will start to show up. They'll start to get more anxious. For many of us, that can be like blood in the water for a shark. We start to worry, we start to chase, we wonder what they are hiding. As they move away, we start to chase even more. This is like a dog chasing the car. The dog does not want to catch the car, it just wants to chase it since it's moving away. When it catches the car, it doesn't know what to do with a mouthful of tire. If you're chasing and playing the game of gotcha with your patients, that's normal human behavior. Everybody's going to run and hide, and it doesn't help either one of you to be chasing them. So what do I suggest? I suggest you normalize their behavior and get curious. Let them know that they're going to want to hide or tell you what you want to hear or make things seem really simple and absolute and concrete in the pain management, which is just not the case. If I ask someone, how do you take your PRN oxy? Every 6 to 8 hours, they will parrot back to me what the prescription says. And I'll say, really? Maybe, but I wouldn't do it that way. I would take them when I hurt. I would take them more some days than others. On some days, I may even actually use more than you told me to. That is normal human behavior. And once they understand that you have some idea about that, and you're not going to simply catch them, then the game changes. They start to educate you about what they actually do, not try to hide what they actually do. It is a dramatic game change, and you'll be amazed at what they actually teach you. And again, I'm not suggesting that you become just purely a patient advocate or that you condone all the behaviors that they might do. I do ask that you understand that their behavior is human nature. I do not need to waste time having a large judgment about it. I need to be able to predict it. This is all tactical. I need all the information I can possibly get to make an informed, rational, and safe clinical decision in this complex person sitting in front of me. Being judgmental, irritated, dismissive, it's not going to help either one of us. Firing them on the spot for normal human behavior is also not going to be very helpful for either one of us. So with difficult patients, or even with difficult people in line at the store, realize that it has nothing to do with you. This is how they are. Also remember, you do not know really everything you assume you know about their behavior. Being right feels safe and comfortable, but does not help understanding. It will not promote a treatment, it will not keep somebody safe, and will not have the outcome that you wish. And all of this is easy to say and hard to do, and I know that well. If practiced and repeatedly considered, it makes the whole of pain management much more satisfying by the end of the day. So how does this help with an opioid pain patient? You'll find that you are able to contain them better. They will not be as poorly controlled with their opioids, and they will tend to not be doctor shopping. All because you are managing them in a way that leaves them feeling understood. You can better keep limits because you know what to expect, not surprised by their behaviors, able to think through how to treat them well but safely. Being able to understand that you are not the target of their personality issues will leave you with more energy, less burnout, less irritability yourself, and a higher satisfaction in your pain practice, hopefully.